every physician caring for patients with obstructive CAD, well, they have to assess risk in the patient that they're looking at, the symptom burden, and then try and figure out what the best approach is for that individual patient. Recently, the American College of Cardiology updated the appropriate use criteria for revascularization. And yet, even with that assistance, it can still be pretty difficult. So what we're going to do today is we're going to talk with the author of a new paper in JACC, and as the accompanying commentary explained it, with concerns about underutilization as well as overutilization, Ko et al. Provide an important step in the evaluation and improvement of the AUC in clinical practice. And let me introduce you the first author of that paper, Dennis Ko, MD, Senior Scientist, Institute for Clinical Evaluative Sciences and the Sunnybrook Research Institute in Toronto. And the paper is Assessing the Association of Appropriateness of Coronary Revascularization and Clinical Outcomes for Patients with Stable CAD. Thank you very much for a few minutes of your time. What were you trying to do in this particular paper?
I think what we were trying to do is similar to what you said. There have been a lot of concern about whether coronary revascularization, angioplasty, and bypass surgery is being appropriately used in patients with stable coronary artery disease. So I think we have a pretty good sense in acute coronary syndrome settings, such as people with having a STEMI or acute myocardial infarction. Most of those procedures are quite appropriate. But I think there are a lot of discretionary use among patients with stable coronary artery disease. So I think this paper really wanted to look at the utilization. So what we did was that we applied the ACC appropriate use criteria and applied to a cohort in Ontario, Canada, and looking at not just overutilization or inappropriate procedure, but also we have an opportunity to look at underutilization, meaning that people who have appropriate indication and might not get the procedures. So those are kind of what we set out to do in the paper.
So what did you find?
I think our findings are quite interesting. So in terms of the inappropriate, so if you look at everybody who got coronary revascularization in a cohort, about 14% of those were inappropriate, 18% of them were uncertain, more than 60% were appropriate. But if you look at the indication per se, so when we started off with the coronary angiography, we looked at people who actually were appropriate for indications, but about 25% of those actually didn't get the revascularization. So that is what we call underutilization, potential underutilization of the coronary revascularization. On a relative terms, if you look at people after cardiac catheterization and they were inappropriate, there's still quite a high proportion of people who were getting the procedure. So I think we identify both sides in terms of inappropriate as well as appropriate procedure, as well as under and overutilization. The other major finding of our study was, in some way, this is a study that we aim to validate the appropriateness score. So what we tried to do was that, well, if the appropriate criteria works, one would hypothesize that patient who got the appropriate who had appropriate indication, got revascularization, should have better outcomes than the appropriate patient who didn't get the revascularization. And that indeed is the case. We looked at 3-year outcomes for death or myocardial infarction, and people who got revascularization among the appropriate patient actually had better outcomes. Conversely, if you look at an inappropriate cohort, that cohort is a bit smaller, there were no difference in the outcome. So I think not only did we identify over and underutilization of procedures, we also kind of provide, a validation, kind of the first study of its kind to say that, well, if you apply these criteria appropriately or apply these to clinical practice, it might benefit patients.
Well, we know that 100% isn't going to be likely because sometimes patients simply don't want a procedure. Where are we in terms of where you think we should be in patients who are or are not getting the treatment?
I think it's difficult to know if we were to put in a percentage. So it is difficult to put a percent. Is it, what should we accept? Is it 1%, 5%, 10%? So I think it's very difficult to use a number to quantify it because patient care is very complicated. And these appropriate criteria really try to distill into a few things: symptoms, medication, the anatomy, and so forth. But I think in the future, what we should do is that if you are doing potentially inappropriate procedure, you ought to kind of say why you did it. is there any other reason that why you did the procedure when you think that it might be inappropriate? So I think that would allow us to understand, what is the potential inappropriate rate in the population. So I think we need more data for those.
So what's your take-home message? What do you get from this paper?
Yeah. I think my take-home message is that wouldn't it be great if we shift some of these procedures that are inappropriate to the appropriate ones? So I think that in terms of the the healthcare resources, right now we are in Canada and both in the U.S. we are in a situation that we wanted to really best use our scarce resources. So I think that in the future, if we can apply these appropriate use criteria into clinical practice, potentially reducing the inappropriate procedure, while on the other side, giving those procedures to the appropriate patient that may improve patient outcomes. So I think the overall utilization would be maximized, or what we call improvement in value in care.
And the paper is in JACC. It's the November 6th issue of the Journal of the American College of Cardiology for CardioSource World News. I'm Rick McGuire.